This time I will really focus, I don't going to speak about steatosis, NASH, fibrosis. I'm going to focus on fibrosis and creating pathway between primary care and liver clinic and how you can use non-invasive method for this purpose, because this is now where the field is going. This is my conflict of interest. So, as been said before, the challenge is to identify patients with NASH, and especially those with advanced fibrosis, because advanced fibrosis are the patients who are the most at risk of developing complication. And as you know, these patients do not die from their liver. They mainly die from cardiovascular event and from non-hepatic cancer. So the challenge is to identify patients most at risk of complication and link them to care. And we know, of course, liver biopsy is impractical and has many limitations for this purpose, given the limited number of hepatologists and pathologists, high number of patients, invasive, prone to morbidity and to sampling variability, also expensive. So it's a non-realistic and risky procedure. So this is the outline I will be following. First, I will stress what are the critical issues when you're using non-invasive tests, because there are a lot of literature, but you have to bear in mind all these critical issues, especially when you want to go to the primary care, where the awareness is low and people have no clue about non-invasive tests. Then a brief review on the evidence in NAFLD, and then I will stress the currently available referral pathways. So these are the available non-invasive tests. We have, among the biological approach, the non-patented tests, very simple, such as ALST ratio, FIB-4 and NFS, patented, for which the pioneer has been the fibro test, but there is the ELF, the fibrometer, the EPA score. And then we have the physical approach, the measurement of liver stiffness. Transient elastography has been the pioneer, but you also have new kids on the block, including RFI, 2D shear wave elastography, and MR elastography. So these are the critical issues you need to bear in mind: availability, cost, applicability, and most importantly, context of use. And this, I will stress the importance of context of use. So for instance, availability and cost. No surprise, if you're going to screen in primary health care, you're not going to start with an MR elastography. And this is, of course, inversely proportional to the cost. So you're going to start with a biological approach and ideally non-patented test. Applicability also is important. It's reliability and failure rate. And if you look, for instance, at the most widely used marker, fibro test, and most biomarkers have very high applicability, whereas FibroScan has reduced applicability if you're not using the proper probe. If you look at the different elastography technique, of course, MR elastography has high applicability, but if you're using the proper probe with transient elastography, then you increase the applicability. Now, context of use. Again, if you want to screen patients in primary care, you're going to start with serum score, not with MR elastography, which is more devoted to tertiary referral center. Importance of context of use. The blue is the PPV, the red is the NPV, and this is the population prevalence of what you're studying. Let me remind you the prevalence of advanced fibrosis is highly variable according to the context. High in the liver clinic where we work, but look, the general population is below 5%. So 25% of the general population has NAFLD, but the severity is low. Only a minority have advanced fibrosis. Now, if you're targeting the diabetic clinic, you can see it's intermediate, but still quite high. So let's see how it translates. If you're in the liver clinic, you see the negative predictive value is high. The positive predictive value is high, but not perfect. But look what happened if you go in the primary health care with a 5% prevalence. Of course, your NPV is almost perfect, but look at the PPV. It's very bad, very bad. So how can we overcome this? So first, let's look at the evidence in NAFLD. Now we have large evidence, as you can see, Chinese meta-analysis, large number of patients, and you can see that the OROCs are pretty similar, but the best validated tests are FIB-4 and NAFLD fibrosis score. Now we have this recent data from the Gilead Stellar trial, large number of patients, but look at the prevalence of F3, F4, very high, 70%. But when you look in this population, this is head-to-head comparison. I mean, it's pretty similar between FIB-4 and ELF, so the added value of patented tests is not much. So performance is similar, but widespread application is limited by cost and availability. Now, if we look at FIB-4 and NFS, they have two cutoffs, as you know, and a high negative predictive value when you're in the low risk, decent positive predictive value in the high risk, and this is about 15% of the patient. But the main drawback is the intermediate, because you have around 30% that fall between the two cutoffs, and you cannot correctly classify. Now, regarding elastography technique in NAFLD, if you look at the evidence, of course, transient elastography outperforms all the other techniques. We have several thousand of patients. It also comes with CAP, and this allows rapid and standardized detection and quantification of steatosis. As I mentioned, the failure rates and the applicability is solved with the Excel probe. It's a point-of-care technique. You use it in your outpatient clinic and you make decisions, widely available, come at an acceptable cost. So this is clearly currently the technique of choice and the most widely available. Also, it has high diagnosis accuracy, again, large meta-analysis from China. But look in practice, which cutoff are you going to use? If you're using the 8 kilopascal, again, the negative predictive value for advanced fibrosis is very high, but above 10 kilopascal, it's a bit disappointing. Positive predictive value is not very high. So a lot of false positive, which was not the case, for instance, in viral hepatitis, where it's been mostly validated. Let's say you increase the cutoff to 14, 15, still the positive predictive value is far from perfect. A lot of false positive. So this you have to be aware. So now how can we use it in our practice, everyday practice, referral pathway? The issue is NAFLD is an underrecognized disease in primary health care. Look at this American study. Less than 10% are referred to the specialist. There are several reasons for that. Of course, there's no symptom, no simple diagnostic marker, but overall, very low awareness of our colleagues. Most GP have no clue about NAFLD, and same for diabetology. So we need to raise the awareness. We also to take into account that despite the high prevalence, the severity is low, as I already mentioned. So which score are we going to use? If you look at the FIB-4, it's age, transaminase, platelet count. Very easy to use, like the MDRD for CKD. You can ask your lab to provide for free the FIB-4. NFS is a bit more difficult. You need fasting glucose of diabetes and albumin. If you ask your GP, most GP, they do not perform albumin, is that they could do it. But if you have a similar test and that is zero and perform as well, they would use the FIB-4. So clearly it's the most suited for primary health care. Now look at the influence of context of use. This is an interesting study from 10 centers in Asia, large cohort. And if you look at the prevalence, the high prevalence we have in our tertiary center. So we are pretty happy if we're using FIB-4 or NFS. But look, when the prevalence is decreasing, the PPV is going down. And if you're less than 5%, PPV, whether you use the FIB-4 or the NFS, is below 30%, which is not acceptable. So very high negative predictive value, poor predictive, positive predictive value. So you need a second test in this high indeterminate category, and also to increase your PPV. And for this, you need a more specific test, So elastography, as mentioned, or ELF has also been proposed, but there is the issue of availability, because in most countries, apart from the UK, ELF is not available. It comes with a cost, and you need a special platform also to perform ELF in your practice. Now, what is the best strategy? Of course, you want to combine. Should we do pair combination or sequential combination, serum marker, then serum marker, or serum marker, then elastography? Pair combination has been studied. This is a study by Salvatore Peta from the group of enterocracy. Large cohort, as you can see, tertiary reference center. If you're going to use FIB-4 and transient elastography, and you will end up, if you use pair combination, with a lot of discordant results. So in terms of misclassified, it performs well, 3%. But the issue is you have a lot of indeterminate results that are discordant, 54%. So overall, the diagnostic accuracy is below 50% because you have a lot of indeterminate results. So the pair combination is probably not the ideal way. What about sequential combination? So as I mentioned, you have a lot of indeterminate results if you use FIB-4. But if you use a second test, then you're going to decrease the rate of indeterminate. This is what we learn, again, from the stellar cohort, large cohort. But again, I want to stress that the prevalence of advanced fibrosis is even higher than what I've shown you, 71%. So not sure we can extrapolate this result to the primary healthcare setting. So again, context of use is critical because most of the data we have come from tertiary centers. So where FIB-4 results are determinate, a second test can further enhance identification of 3F4, whether it's ELF or it's FibroScan. So now we have a recent example from the UK, and we move from selected patients to real-life population, and this is the so-called Camden-Islington algorithm. So let me just take a little bit of time to detail. You start with FIB-4 in the patient you suspect of NAFLD, and of course, you have to rule out viral hepatitis, HPV, HCV, and alcohol. So if you're below 130, you have low risk, you can be managed in primary health care. If you're above 325, you're high risk and you should be referred. In between, there come the ELF test. And either it's below 9.5 and you fall in the low risk category, or it's above and you're in the high risk category. So large cohort, 1,000 and almost 500 patients, and look how it translates. 70% fall in the low-risk category, but then with ELF, you have an additional 11%. So in total, about 80% do not need to come to the hepatologist. On the other end, you can see that the remaining will be coming to the hepatologist, and again, around 60% with the ELF will come. So the interesting thing about this study is that they compare on referral the standard of care and the so-called NAFLD pathway. What you can see is there was a decrease in non-necessary referral, but still 70%, and an increase in the proportion of patients with advanced fibrosis that you can capture. The drawback of this study, there was very few liver biopsy. Of course, they did not perform liver biopsy in every patient, but still, it gives you an idea, and I think this is an interesting proposal. So 2 steps, FIB-4 followed by ELF, if required, reduce unnecessary referral, also improve the detection of cases, advanced fibrosis 5-fold. The issue, as I mentioned, the ELF is not available in most countries, including in France. Now, what about diabetics? So as you know, they are high risk, but the prevalence is much higher, close to what we're seeing in our center. And in this setting, I'm not sure using, of course, FIB-4 is easy to do, but a sequential algorithm is really worse. You can go directly, I think, to transient elastography. There were 2 studies. The first study was performed by the group of Henry Chan a few years ago, and they screened systematically in the diabetology clinic 2,000 a Chinese diabetic patient, and you can see the prevalence, if you're using a cutoff around 10, was very high, 18%. We have a similar study by Dominique Rouleau in France, who is showing results with lower prevalence also of advanced fibrosis. So just before concluding, how can we use in clinical practice? This is the algorithm. It's an adapted algorithm that one we published last year. So if you're screening in primary health care, you need a sequential algorithm. You start with FIB-4, and I think if you want to address the GP, you need a very simple message. Below 1.3, you keep the patients. Above 1.3, you send the patient. You refer the patient to the hepatologist. Otherwise, if you start with a dual cutoff strategy, it will never work. It's very confusing for them. Then, of course, you will use what is available in most centers, that is FibroScan, and you can rule out if you're below 8 kilopascal. Above, you consider liver biopsy on an individual basis. I don't say you have to take a liver biopsy. You consider liver biopsy, and of course, what makes a difference is availability of stereotypical trial where you can enroll your patients, but beware of the false positive. Now, if you're in the context of the diabetology clinic, I think as first line, you may already use the FibroScan. You don't need a serum test, and you apply the same algorithm, and then you consider liver biopsy if you're above 8 kilopascal. And this is what we are currently doing in a big grant called the RHU Quid NASH in France. So these are my take-home message. As you know, FIB-4, NAFLD, fibrosis score, transient elastography are the most widely used and best validated, but FIB-4 is the most suited for primary health care. Availability, cost, applicability, and context of use are critical issues when using non-invasive tests. Optimal way to identify patients with advanced fibrosis is a sequential use of FIB-4 and NFS, then transient elastography to select those who should be considered for liver biopsy. And I hope I convince you now the next step is to create effective pathway for primary health care and diabetes clinic, because this is where the patients are actually. And in order to identify those who need to be referred to the liver clinic and for further assessment. Thank you very much for your attention.
Thank you, Laurent, for the nice presentation. So we have time for some questions, because finally it's... Yes, the pathologist, okay.
Sorry, it's me again. Thank you so much, Laurent, for this very nice talk. But it seems to me that you miss half of the problem, because NAFLD is a disease with two components. One is fibrosis, and the other is activity, is NASH. So we have a marker for advanced fibrosis, which works more or less. But what about NASH? And if you select the patient to biopsy, because they have advanced fibrosis based on your non-invasive marker, you will miss all the patients which have not this advanced fibrosis, but which have a severe NASH. So again, my question is, why you did not address the problem of NASH biomarker, and where are we in this field?
Okay, so just to be didactic, of course, as I mentioned, I did not go through steatosis, NASH, advanced fibrosis trials, just to focus and to deliver a simple message. But you're absolutely right. NASH is important. The issue is, currently, we don't have a good non-invasive biomarker for NASH. Of course, you can suspect NASH, for instance, if you have many metabolic risk factors. If you're type 2 diabetic and obese, for instance, the probability of NASH is high if you have elevated transaminase. So the population I'm targeting is not a systematic screening, is the patient with risk factor and elevated transaminase. And as you know, for instance, in the RHU Quid NASH, this is what we're doing in diabetics. And the prevalence of NASH is around 30%, where we're doing liver biopsy in patients with steatosis on ultrasound, which is 90% of diabetic patients, and those with slightly elevated transaminase. But still, the prevalence of advanced fibrosis is around 30% as well in all comers in the diabetology clinic. So this means that this is really an issue, because they will not die of NASH. They will die of advanced fibrosis because it's related to cardiovascular complication.
Yeah, but from the academic point of view, if you want to make a diagnosis of NASH, Laurent has shown that this method allows you to select a portion of patients that will undergo liver biopsy. So you want the best market, the best way to find out if a patient has NASH is still histology. I don't know any markers that predict ballooning, or there is like CK18, which is a marker of apoptosis, but there is nothing really relevant. So if in the end you can reduce the number of biopsies and make a precise diagnosis histologically, I think this is the aim of the non-invasive markers.
Laurent, what's about non-invasive markers in treated patients? Because very soon we'll have maybe effective treatment, effective drugs. So how can we do with our non-invasive markers? And first question, can we avoid liver biopsy for the treatment of patients, or do you think may have some good markers to say, okay, this patient is eligible for drug treatment?
So there are two questions in your question. Basically, is how can we use our non-invasive method to enrich the populations that may be eligible for treatment? And I think for this, the non-invasive method works pretty well. But this is, again, a selection for patients for liver biopsy. And for instance, recently it has been proposed, and I know the paper is in press in the Lancet GH, the FAST score. So it's very easy. You can implement it in your clinic next week. Is AST, CAP, and elasticity. And then you end up with a score, and this gives you an OROC about 0.85 of the likelihood of having fibrotic NASH, and you might be a candidate for a therapeutical trial. But still, you're missing some patients. Now, the definition, again, has been emphasized, and I think Pierre will address this later on. The definition of NASH is not completely clear, including on liver biopsy, because according to the SAF, to the impression of the pathologies of the NASH CRN, you have different answers for the same disease. So it's not completely solved. Now, for the follow-up, of course, of treatment, this would be an attractive strategy, but I have to say that so far, what we have is pretty disappointing. In terms of NASH resolution, you cannot use any non-invasive marker. Instead, in terms of steatosis evolution, MRI-PDFF qualify as a very accurate technique for quantifying steatosis. The follow-up data, I think we need to be cautious, even though now all the phase 2 studies tend to use this as an endpoint, but there is no clear cutoff and no clear definition of what is a significant improvement, because we don't know how it's related to harder outcome and longer-term outcome. So I think this is an important message. As for fibrosis, if the question is whether liver stiffness is a good surrogate of the improvement of fibrosis, the answer is, I don't know. And if I look what happened in the HCV field, where most data have been published, still I don't know either, because we don't have a good study with paired liver biopsy showing that the improvement of liver stiffness in HCV cirrhotic cure with DAA is related to an improvement in fibrosis, because this is polluted by inflammation and not related to longer outcome. So let's be cautious. There's a lot of interest and pressure to impose some technique like MR elastography as a surrogate, but I think you have to be cautious because it's not evidence-based so far.
We must almost close the session, but we have still a last question regarding the cutoffs for HIV-infected patients. Are they different? What can you say about
Sorry, for?
HIV. HIV.
What do you mean?
The VIH. Cutoff for
The
fibrosis.
performance of the non-invasive markers.
Oh, in HIV? Yeah. Okay, it's not NAFLD.
No, but within NAFLD you may have.
I don't think they're really different in HIV. Alone, you mean, or co-infection, HIV, HCV?
No, I think for the FIB-4, yes, it's less performant in the HIV infected because platelet counts very frequently is...
Sorry, I missed the point. I thought you were talking about transient elastography. No, FIB-4 NFS, you have to be cautious because of the platelet count. Also, I did not mention you probably need to adapt the cutoff according to age, because age is part of these two tests. And then you have to adapt the cutoff in elderly patients. And as you know, NAFLD is usually a disease of the 5th or 6th decade. So this is important in your practice.
Okay, I think we can thank you very much, Laurent, for this very nice discussion.